Good morning, respected seniors, faculty members, practitioners, and postgraduate students. A very good morning to each one of you, and I welcome you to the third session of our webinar series, Decoding Salivary Gland Tumors. At the outset, I would like to express our heartfelt gratitude to all our participants for the overwhelming response we've had, around 650 registrations up till now. A very big thank you to each one of you for participating. And today's session is the third segment of this whole series. In the session one, we covered the basics of histology of salivary glands in detail, the non-neoplastic lesions. In session two, we elaborately covered all the benign salivary gland neoplasms. And in this third session, we shall be covering malignant salivary gland tumors. Now, according to the latest WHO 2022 classification, they have enlisted about 35 entities, of which 20 are malignant. And this classification is constantly evolving, is changing according to the new discoveries or identification of the biological behaviors. So restricting ourselves to rote learning is going to make things very difficult for each one of us. So a very clear understanding of their nature, their histopathology, their clinical features is absolutely imperative to understand them rather than to learn them by heart. And today's session will be covering all these entities in absolute detail. And I really hope that this session will be useful to each one of you. And I request our speaker for this whole series, Dr. Punyangadi ma'am, to please take over.
Thank you so much, Subbalakshmi. And at the outset, I would again thank Dr. Jayanta and Dr. Subbalakshmi for inviting me to be part of this series. And without further ado, I think we will start with the session. Share my screen?
Yes, ma'am.
Not able to share it. I'll share it again.
Just a note for all our attendees, again, you have been muted by default. If you wish to pose a question to our speaker, please record it in the chat box. We will be addressing the questions at the end of the session. And for all our attendees, you will be getting your attendance certificates mailed in the next 1 or 2 days, along with the feedback form. And we request all of you to please fill in the feedback form for us to get a very clear idea about how we can improve as an institution in conducting these sessions. And they are going to be extremely beneficial for us for our future endeavors. Thank you very much. Yes, ma'am, we can see your screen.
Moving to, can you see the next slide?
Yes, ma'am, we can.
Okay, so I'll begin. So this is the last session for the webinar series. So we will be covering malignant salivary gland tumors today. We started with the foundations, non-neoplastic lesions, and then the benign salivary gland tumors and the malignant salivary gland tumors. So the malignant salivary gland tumor presentation will be be similar to your benign salivary gland tumors, in the sense that we will be continuing with the same sort of a diagnostic framework that we developed for the benign salivary gland tumors, but with certain changes, of course. So malignant salivary gland tumors account to 15 to 30% of the salivary gland tumors, but they are extremely rare. They are less than 1% of all the head and neck malignancies. The most common one that we encounter are the adenoid cystic carcinoma, the mucoepidermoid carcinoma, and the ethnic cell carcinoma. So ethnic cell carcinoma is something which I have not seen much. Definitely adenoid cystic carcinoma, mucoepidermoid carcinoma are more common to be encountered. Coming to the location, again, parotid is the most common site, followed by the submandibular. Then you have sublingual coming in. 80% of the tumors occurring in sublingual salivary gland are malignant, and then you have minor salivary gland. So we had this rule of 80s, which we covered in the benign salivary glands, where we saw that 80% of tumors occurring in parotid are benign. So the rest 20% are malignant. In submandibular, Out of all the salivary gland tumors, about 50% will be malignant. In sublingual, 80% malignant, and in minor salivary gland, 50 to 70%. So a practical tip, the smaller the gland, the higher the chance of a tumor being malignant. So more commonly in a parotid, you're going to think of a benign tumor, but if it is occurring in a sublingual or a minor salivary gland, you have to think of malignant salivary gland tumors because they are more common in these particular glands. So what makes the tumor malignant? Before we identify it, before we name it, as Dr. Subbalakshmi very clearly said, that WHO has so many entities, and definitely this webinar was not trying to name all those entities. We are trying to actually see how we are going to diagnose them and how we are going to identify behave. So the key behavioral clues that should point to malignancy, apart from the clinical presentation of rapid growth, fixity to the underlying tissues, facial nerve involvement if it is a parotid swelling, and if there is and the presence of it is not normal. So all these should be pointing towards a malignant salivary gland tumor. But if you're seeing it in histopathology, what you need to look for is no capsule or loss of encapsulation, infiltrative margins. Just a second. Infiltrative margins, presence of perineural or vascular invasion, destruction and extension into the adjacent tissues, presence of necrosis with or without desmoplasia, increased mitosis and atypia. If you find all of these in a tumor, then you have to think of a malignant salivary gland tumor. So malignant tumors invade, they don't just expand. So malignant salivary gland tumors are not difficult because they are dramatic. They are difficult because they are very deceptive. Why they are deceptive is they often look very bland. They look very well differentiated and orderly, but they invade, destroy, and spread. Traditionally, in oral pathology, whenever we think of a malignant, we really look into the cytologic changes, especially a squamous cell carcinoma, which is a prototypical carcinoma that we all as oral pathologists encounter. It shows, it is very ugly to look at. It has its pleomorphism, it has hyperchromatism. There is a lot of atypical mitosis, which you can see, and it clearly points to a malignancy. But when you come to salivary gland tumors, they are cytologically bland. So they challenge this rule of pleomorphism, hyperchromatism, and atypia. And most of the glandular epithelial cells are itself, by nature itself, they are hyperchromatic. So you cannot say that they are malignant. So what are the red flags that you have to look for? So cytology is not going to help you much when you're diagnosing malignant salivary gland tumors. What you again need to fall back to is architecture. So you have to look for infiltration, you have to look for perineural invasion, presence of necrosis, loss of encapsulation. These are the key that will point to malignancy in salivary gland tumors. So why malignant tumors confuse us? There are more than 21 new entities in the 2022 WHO classification. But what is more confusing is most of these have overlapping morphology, and histologically they may appear very similar. Okay, so and there is a spectrum which is there. You have low grade and high grade, and you just cannot give a name of mucoepidermoid carcinoma and keep quiet because the management is going to be totally different if it is a low grade mucoepidermoid carcinoma, high grade spectrum. I already mentioned about the cytologic blindness. There will be multiple patterns in a single tumor. And there is a concept of dedifferentiation, which is high grade transformation, which can occur in a low grade tumor. There are a lot of hybrid and mixed carcinomas, and there are newer entities which are more molecularly defined in the sense that there are specific fusions and genetic changes which are there, but microscopically may resemble a tumor which is previously named. So it would be safe for us, rather than going to name them, it is always better to identify whether it is benign or no by its behavior. So what this, and on top of that, the classification that I would prefer would something which divides the tumors into low risk, intermediate risk, and the high risk, that is the AFIP classification, which classifies the tumor based upon how it is going to behave. But again, you should remember, same name, not equivalent to same behavior. So if you see in the low risk, we have mucoepidermoid low grade. We have intermediate risk, again mucoepidermoid carcinoma, but the intermediate grade, and the high risk has got high grade. So you have tumors which are having the same name, but they do not actually behave in the same. And the same pattern does not mean it's the same tumor. So cribriform traditionally believed to be in adenoid cystic carcinoma, but you also find it in other tumors. So it is not a classical pattern which is definitely seen in adenoid cystic carcinoma. It is definitely seen, but it doesn't mean that it has to be adenoid cystic carcinoma. Same cytology, same prognosis? Definitely no. You may have a cytologically bland tumor like adenoid cystic carcinoma, which has a very poor prognosis. So these are some of the things that you need to be clear when you approach a malignant salivary gland tumor. So what will today's session do? So we are going to cover malignant salivary gland tumors, patterns first, behavior always, and names last. So we are going to classify malignant salivary gland tumors by identifying the behavioral red flags, apply the pattern-based buckets as we did for benign to routine diagnosis, then go for the cytological assessment, and we are going to avoid common diagnostic pitfalls. So why a pattern-based approach? As I already mentioned, cytology is something that you cannot actually rely on in salivary gland tumors. So architecture is a more reliable as compared to cytology. So we are going to take a pattern-based approach. So architectural pattern, we are going to divide malignant salivary gland tumors into three. The first one is solid, then we have cribriform, and the last bucket is the cystic or the cystic papillary. So coming to the solid bucket, so solid tumors should be considered as high grade. They usually represent a danger zone. So what you see here is sheets and nests of cells. There will be minimal true lumina or true duct-like spaces. There's a lot of cellular hyperplasia. They appear to be baseloid or often high grade because of the hypercellularity. Necrosis may be present. So under this category, we have basal cell adenocarcinoma. We have the solid variant of adenoid cystic carcinoma. We have high grade mucoepidermoid carcinoma. We have another high grade neoplasm, that is salivary duct carcinoma. And then we have carcinoma X, pleomorphic adenoma, and myoepithelial carcinoma. So all of these are hypercellular. They appear to be very active, and then there'll be presence of necrosis, which you need to look for. So the key learning points that you need to look for is look for infiltrative borders at low power, especially for basal cell adenocarcinoma, the basal cell adenoma. You have to look for infiltration, look for loss of encapsulation, actively search for necrosis and mitosis, and ask to be benign, especially true for a basal cell adenoma. Is it too cellular to be benign? Look at the periphery. Always exclude carcinoma X, pleomorphic adenoma whenever you're seeing any solid malignancy growth, and you find perineural invasion, then it is definitely a malignancy. So solid salivary gland tumors are guilty until proven innocent. So the next architectural bucket is cribriform tumors. So cribriform tumors usually have punched out spaces or pseudocysts, which can be seen, which is dominating throughout the entire slide. True lumina may also be present in the sense duct-like areas. Presence of these hyaline globules can be seen. You have cribriform architecture, or sometimes you may have tubular, but the cytology is deceptively bland. So you have uniform isomorphic cells without any pleomorphism and a bland cytology that can be seen. But remember, they are bland, but they can be invasive. So what comes under these? You have adenoid cystic carcinoma, you have polymorphous low-grade adenocarcinoma, you have secretory carcinoma, and low-grade adenocarcinoma not otherwise specified. So all of them have this cribriform-like appearance. The cells appear to be deceptively bland, but they invade. So cribriform is not always ACC, remember, until proven otherwise. Most commonly seen in ACC, but you can also see in other tumors. If you are suspecting ACC, look for angulated nuclei, presence of hyperchromasia, because the cells are inherently hyperchromatic. It is not hyperchromasia related to malignancy. Look for perineural invasion. Remember, bland cytology does not exclude malignancy. If you have a lot of architectural diversity along with the cribriform pattern, think of there are papillary cystic areas along with cribriform of secretory carcinoma. So cribriform tumors whisper malignancy. They do not shout it as the solid tumors. Last pattern which we are going to consider is the cystic pattern, or the these are the ones which are most commonly underdiagnosed and most undercalled as malignancies. What you see here, you have large cystic spaces which are dominating. You may have papillary fronds which are going into the cystic spaces. You may have mucin pools, and you may have epithelium which can be flattened or it can be cellular, and they are often mistaken for benign cysts. So what comes under this? You have your low-grade mucoepidermoid carcinoma, Then you have cyst adenocarcinoma, which can be papillary and non-papillary, which are the most common ones. The key learning points here is cysting is not benign. Always exclude the low-grade mucoepidermoid carcinoma. Look for invasion into the stroma. Actively search for intermediate cells, which are very specific for mucoepidermoid carcinoma. There are presence of papillary fronds in the cystic space. Does not always mean it's a ductal papilloma. It could be a cyst adenocarcinoma. So any cystic salivary lesion in an adult should be considered malignant until proven otherwise. So look for all of this. If you do not find any of this, then only sign it off as a cyst. Also, cystic tumor of the underdiagnosis usually happens. So once we do the architecture, then we go for cytologic assessment. This is similar to your benign tumors. You have one cell type, two cell type, and then you have the specific cell types. So two cell types composed of luminal, abluminal, usually either luminal or abluminal, and or you can go for specific cell types. So I would prefer to go for specific cell types. So once you see the architecture, go into the cells, look for whether they are uniform cells, whether they are isomorphic, whether they are baseloid, clear cells, spindle cells, or are they angulated cells. Based on that, you can give the classifications. Or they can be biphasic, like you have your epimyoepithelial, where you have both intercalated and myoepithelial cells. Okay, so this is the diagnostic algorithm. Always scan at low power. If you find that the lobular architecture is maintained, you're going to give it as a non-neoplastic. If there is encapsulation, you're going to call it as benign. No encapsulation, infiltrative, invasive, you're going to call it as malignant. Then you're going to put it into an architectural bucket, whether it is solid, cystic, or cribriform. Do the assessment, and if required, you can go for IHC. So the general features, they are again seen in elderly. Females are more commonly affected than males, but there are some which commonly affected males, like you have papillary cyst adenocarcinoma, salivary duct carcinoma, carcinosarcomas, and now oncocytic carcinomas, which are more common in males. Clinical presentation: rapid growth, pain, ulceration, fixity to the tissues, facial palsy. These are some things that should hint towards a malignancy, whereas a benign tumor will be slow growing, asymptomatic, and completely harmless. And they have some site specificity in the sense that major salivary glands, most commonly you get a basal cell adenocarcinoma, you get carcinoma ex pleomorphic adenoma, stick cell carcinomas, more common in major salivary glands. In minor salivary, common is mucoepidermoid carcinoma, followed by adenoid cystic, and then you have your PLGA, which are more commonly seen in minor salivary glands. So that could also hint towards the diagnosis. So let's go to individual tumors now. The most common one, it's not common in the sense common with regards to incidence, but it's common when we actually study salivary gland tumors. So it's carcinoma ex pleomorphic adenoma. What you need to look for here is there should be a history of a pre-existing pleomorphic adenoma, which has shown recent rapid increase in growth and facial palsy. So there will be a typical biphasic morphology in the sense you have the benign pleomorphic adenoma, and along with it, you have the malignant epithelial component. This malignant epithelial component could be either a salivary duct carcinoma, it could be adenocarcinoma, not otherwise specified, or you can have a myoepithelial carcinoma arising in a pre-existing benign pleomorphic adenoma, and that is the only case scenario that you will encounter myoepithelial carcinomas. Otherwise, they are extremely rare. So in a pre-existing pleomorphic adenoma, occurrence of a myoepithelial carcinoma pretty common, and that's the only place that you will be able to see myoepithelial carcinoma. Otherwise, very difficult to see these cases. And then you have even a squamous cell carcinoma arising in it. So apart from these carcinomatous components, you have to look for necrosis, you have to look for mitosis, you have to look for capsular invasion. I cannot repeat it more. These are the only things that will hint towards the malignancy and the clinical presentation. Otherwise, the atypia may not be as glaring as in a squamous cell carcinoma. And the grading can be done depending of involvement. So these are the clinical photographs. Typical benign pleomorphic adenoma, very benign. Here you can see that there is ulceration, there is necrosis, and there is fixity to the underlying structures. There may be ulceration. Patient may have pain, facial paralysis. Okay, so you can see this is a typical benign pleomorphic adenoma focal area, which is showing pleomorphism and is extending into the capsule. This is very minimal invasion beyond the capsule. Here you can see a highly cellular area along with the typical myxoid, which is showing a lot of cellular atypia and focal area of necrosis can be seen here. This is infiltrating islands which are going into the myxoid areas, and you can see the cytologic atypia which is clearly seen. This is the salivary duct carcinoma, which is developed in a pre-existing pleomorphic adenoma. This is another one where you can see necrosis, and there is cometonecrosis, which is seen, which is very typical in a salivary gland tumor. So cometonecrosis is necrosis which occurs in the center of the island because of loss of or ischemia, or because of loss of decreased blood supply in that particular area. So this was a case which we got in the palate. It was also a proliferative lesion. It was provisionally diagnosed as squamous cell carcinoma, and maxillectomy was done and sent to us. And when you see it, it was looking like a well-differentiated squamous cell carcinoma with lot of keratin pearls, lot of islands proliferating downwards, and also extending into the epithelium. So when we saw multiple sections, there were some clear cells which were evident at multiple areas. When we went to the higher power, you can see these clear cells which were seen in multiple areas which were resembling myoepithelial cells. So you can see the angulate myoepithelial cells in a typical epimyoepithelial pattern, or the duct-like areas which were seen deeper down. So in multiple areas, we could see these typical areas which are seen in pleomorphic adenoma, with the central area of eosinophilic coagulum, and then you have your intercalated ducts, and then you have your myoepithelial cells in multiple areas. We could see this, and then on multiple sampling, we could see some areas of hyalinization as well. Okay, so again, a high power view of typical pleomorphic adenoma like areas. So we finally gave it as a carcinoma X pleomorphic adenoma. So multiple sampling is something that I need to hint here for giving a diagnosis of carcinoma X pleomorphic adenoma, because you need to have a typical area of a benign pleomorphic adenoma to give a diagnosis of a carcinoma X pleomorphic adenoma. If you do not get an area of pleomorphic adenoma, benign pleomorphic adenoma, you would have signed it off as a squamous cell carcinoma. So for a diagnosis of carcinoma X pleomorphic adenoma, you have to have the entire specimen, you have to go through the entire specimen, take multiple sections, and then only you can come to that particular diagnosis. So the next most commonly encountered tumor is the adenoid cystic carcinoma. It is also referred to as cylindroma. I will explain the reason for that. So adenoid cystic carcinoma is very bland under the microscope, very brutal in behavior. It's considered to be an indolent malignancy, slow growing, but it has high chances of undergoing metastasis, and it is very aggressive. It infiltrates into the adjacent structures, and many a times when the adenoid cystic carcinomas are diagnosed, it would have already metastasized to the lung or to the brain or both. So the key features that, so it's also referred to as a wolf in a sheep clothing. So it behaves very indolent, but it's actually very aggressive. So you see here is you have uniform hyperchromatic or dark cells, and they have angulated nuclei. They are isomorphic. There is no pleomorphism anywhere. But they can be present in multiple ways in the cell's arrangement. It could be either tubular, or it could be cribriform or solid, even as per that. So, and also they have extreme neurotrophism, in the sense that to spread to the nerves and perineural feature that you need to look for in adenoid cystic carcinoma. Pattern plus neurotrophism is diagnostic for adenoid cystic carcinoma. So this was a case which occurred as a swelling in the palate, and we did a CT scan, and you could see that it had maxillary sinus, the nasal cavity, and almost into the orbit. Okay, displacing the orbit on one side. If you could see this particular area, you can see it is also extended till the base of the skull. This is the extensive lesion which was seen, and this was the gross sent to us. And if you see the cut surface, it was whitish, well circumscribed, but still extending into the underlying lot of the structures and causing destruction of the structures. What I need you to focus here is solid. Okay, so you have a lot of the cystic spaces which you can see in the microscope, but you cannot see it grossly. So that means that they are all microcysts, cysts which are seen only in the microscope, or they are also pseudocysts, in the sense there is no activation happening here. It's just appearance of hole within a sheet of cell. So you do not have actual cystic degeneration happening in adenoid cystic carcinoma. So let's see the histopathology. You can see there is invasion, there is no capsule, and you have the pattern that you are going to put it into is cribriform, nice punched out holes between the sheets of cells and lined by cells, and the cells are basiloid or hypochromatic appearing cells. Okay, so this is a classic view of adenoid cystic carcinoma. It is also referred to as the Swiss cheese pattern, so or the sieve-like pattern, and they also appear as cut section of cylinders. That's why the previous name was cylindroma. So what you see here is usually you have sheets of cells which are being separated by these small cysts. They are pseudocysts, they are not actual cysts, they are not actual ducts because they do not have any microvilli, and actual ducts in adenoid cystic carcinoma may be very difficult to get. So predominantly you have these sieve-like areas. Cheese pattern is what it is. So this is a characteristic finding. At least in a focal area, you find this, you have to suspect adenoid cystic carcinoma. And then you may have this stroma, which is more hyalinized. Typically, you have a hyalinized stroma, which is separating these Swiss cheese-like pattern. You can have these cysts, which may be of varying sizes. Focal areas may show presence of tubules. So tubules are nothing but elongated duct-like areas. Again, here you can see a mixture of the cribriform pattern and the tubular area, which is separated by the hyalinized connective tissue. This is entirely tubular. So the grading usually varies depending upon the, if you have a tumor here which has both cribriform and tubular, you may think that what should I name it? So if you have to look for the areas, if it is more than 30% tubular, you're going to give it as a tubular variant. If it is more than 30% cribriform, you have to go in for a higher grade and call it as a cribriform. So tubular is a low grade, cribriform intermediate grade, and solid is the high grade one. And solid is something you need to look for because it has very poor prognosis. So these are again your tubules. And look at the cells. The cells are usually cuboidal, round to ovoid. They have this angulate nuclei in the sense they are not round. They may be slightly elongated and angulate. And true ductal lumina are very rare. If you find, you may have some eosinophilic material within them. And this cyst may contain eosinophilic material which is PAS positive, or sometimes it may also be mucoid material which is Alcian blue positive. Okay, so this can be mucoid material which is Alcian blue positive. Whenever you have a case of adenoid cystic carcinoma, look for perineural invasion. So they have a propensity because of the neurotropic factors which are secreted by the epithelial cells. So they have a propensity for neural invasion, and they also cause skip metastasis because of that. So is something that you need to look for. So this was another case that was very benign looking, very bland. There was no areas of necrosis, of course, infiltration, invasion, and clinically also it was a very aggressive neoplasm. This had some amount of necrosis. This case did have some necrosis and also true cystic degeneration, which was seen in many areas. Again, you can see the variation, the pink or eosinophilic material that can be seen within the cystic spaces. And then you have these cells which are arranged in sheets interlacing trabeculae. Here you have mucoid material which is filled. I wanted to show another area. So this is your typical cystic. You can see that they appear dark, hypochromatic, uniform. Usually do not find much of mitosis, especially in the cribriform and the tubular areas. You can see that in solid, you have these interlacing trabeculae or interconnecting cords. The hypo view with the angulate nuclei. So this was another case where you had tubular areas. Focal area of definitely cribriform area does give you a diagnosis of ACC, but in many areas we had these solid islands. Okay, a lot of solid islands. Again, you can see here a focal area showing cribriform pattern. They were arranged in the form of islands and sheets. Okay, again, this is a hypo view. These are your tubules, and these are your solid areas. So remember, if more than 30% solid areas in the overall tumor, you're going to call it as a solid ACC because the prognosis varies and it is more considered to be more aggressive. Okay, so it's more than 30%. I'm sorry, it has come 20 there. Okay, so these are your solid areas. Okay, so this was a predominantly tubular tumor with more than 20 or 30%. Yes, so we are going to grade it as solid. Okay, so this was a tumor which was predominantly solid. So you had sheets of cells and you have this typical necrosis in the center, which is called as the comedonecrosis. And this is very characteristic in salivary gland tumors, usually seen in a solid ACC and a salivary duct carcinoma, because they are considered to be extremely high grade carcinoma. You can see these cells again, they are dark, hyperchromatic. In the solid variant, you can, to a certain extent, identify some pleomorphism, in the sense you can have these prominent nucleoli, presence of these atypical mitosis, and presence of slight pleomorphism is something a solid variant. Otherwise, it is a deceptively bland neoplasm. You can see a lot of mitosis here. Okay, so there is brisk mitosis and this comedonecrosis, which suggests it is a very high grade malignancy. So this is a solid variant of ACC. That's about adenoid cystic carcinoma. One more tumor which presents with cribriform pattern is your cyst adenocarcinomas, more commonly seen in the parotid, and they usually present as the papillary or the non-papillary variant. So this was a case adenocarcinoma occurring in the parotid. So you can see there are a lot of cystic spaces, and within that you have these papillary fronds which are lying there because of the cross section. Apart from that, you can also see these cystic spaces which are resembling cribriform areas. So you can see these cribriform areas again, but here you need to look for the cells. The cells are completely different from what you get in a adenoid cystic carcinoma, and also you have these papillary projections which should point to a cyst adenocarcinoma. Okay, so you can see the cells, they are not dark, hyperchromatic, minimal cytoplasm that was there in adenoid cystic carcinoma. Here you have abundant cytoplasm, abundant eosinophilic cytoplasm with a centrally placed nucleus, and you can see these papillary fronds with the central connective tissue core, and these are your cribriform-like areas. A hypo view of the same. You can see the cells, the abundant eosinophilic cytoplasm with a centrally placed nucleus, which can have a vesicular nuclei. You have these cribriform areas, few mucinophages seen within them. Again, papillary projections giving a hobnail-like appearance. Okay, again here you can see the hobnailing, and these are your papillary fronds which are lying within the cystic space. Okay. So again, you have these papillary fronds, and then you have your cribriform-like area. So remember here, the cysts are seen which are resembling like cribriform, but the cellularity is totally different. So architectural bucket, then go for cytological assessment. So cytological assessment will show you that they are vastly different from what you get in a adenoid cystic carcinoma. These are considered to be intermediate grade tumors, and you have these typical papillary projections that you can see. So this is a papillary cyst adenocarcinoma. Again, you can see this areas of hobnailing, which you can see very clearly projecting into the cystic spaces. So the next one is basal cell adenocarcinoma. So basal cell adenocarcinoma, very difficult to differentiate it from basal cell adenoma. They resemble each other very much. They look very familiar like adenoma, but they behave like a traitor. So when you have basaloid tumor and you see that there is infiltration and there is invasion, you have to suspect a carcinoma. So if there is loss of circumscription or invasion, you have to suspect a basal cell adenocarcinoma. It is a low grade malignancy. It will not show you pleomorphism. It will not show you a lot of atypia or mitosis. But what you need to look for is presence, and even perineural invasion is not a characteristic feature of basal cell adenocarcinoma. It's considered to be a very low risk or low grade malignancy. What you need to look for is basically the periphery. If there is infiltration, if it is extending into the adjacent tissues, there is no circumscription, you have to call it as a basal cell adenocarcinoma. So more common in the parotid. This was a rare case which was seen in the palate. You can see the clinically also it is very not having the typical feature of a benign salivary gland tumor. So malignant salivary glands usually grow to a larger size. There are multiple ulcerations, which means that there is irregular growth which is happening within. Okay, so this is the radiograph which is showing that the tumor had extended into the palate as well as extending onto the maxillary sinus. What we saw histologically was sheets and islands of baseloid cells. There was no circumscription. They were extending into the adjacent tissues that were present here. You can see these sheets and islands seem to be separated by some basal lamina-like material. Areas of necrosis were also seen. So areas of necrosis should hint to a malignancy. Okay, again here you have baseloid cells. So baseloid cells typically cells with minimal cytoplasm appear dark, hyperchromatic, resemble the basal cells of a oral epithelium. That's the reason they are called baseloid cells. Have closely placed sheets of cells, and then you have these basal lamina-like material or connective tissue septae, which are separating them. Another view of that. You can also see within the tumor, there are some droplets of eosinophilic material. Another area which is showing it's invading into the overlying epithelium, invading into the bone. So definitely points to a malignancy. Yeah, you can see the peripheral palisading, which is very clearly seen in this particular tumor. So in basal cell adenocarcinomas, peripheral palisading is something that you need to look for. The peripheral cells are usually small cells, but they have a palisaded arrangement. The central cells will be larger. Okay. It also showed some comedonecrosis. Areas of squamous metaplasia are also seen here. Even here, you can see areas of squamous metaplasia. Again, comedonecrosis, cystic degeneration, and then you have these whorled eddies, which are squamous metaplasia arranged in the form of whorls. They are called as squamous eddies, which is very characteristically seen in basal cell adenomas as well as basal cell adenocarcinomas. A view of the same, and this is path showing the squamous eddies. So the basement membrane material was very striking, and that is one of the things that you need to look for in a basal cell adenocarcinoma. You have a lot of reduplicated basement membrane, which will be path positive, can be seen both in basal cell adenomas as well as in basal cell adenocarcinomas. In numerous places, we had extensive amount of basal lamina, which was highlighted by the path stain. This is separating the cells in the form of a lace-like pattern and also forming a alveolar pattern, which you can see in the path as well. So the types of cells that you see, the peripheral cells are small. They're described as small, but they will have a palisaded arrangement in the sense they are regularly arranged. The central cells are usually large. They will have little bit of cytoplasm, and they are also, you can see there is some amount of mitosis which can be seen here, and there is some amount of nuclear can be appreciated. So this was the case of basal cell adenocarcinoma. So the next tumor is mucoepidermoid carcinoma. So it looks very harmless at low grade. It actually may be confused with a mucocele, but it hits hard at high grade. So the key features, as the name suggests, you have to look for the 3 cell types, that is mucus, epidermoid, and the intermediate cells. And it can be cystic and solid depending upon the grade. So if it's a low grade, it's cystic with a lot of mucus cells. If it is intermediate grade, it's a mixture of cyst and solid. And if it's a high grade, it's predominantly solid, and it may show pleomorphism. It may show mitosis. Okay. So mucoepidermoid carcinomas, you should remember 3 things about it. It's the most common malignant salivary gland tumor. Second thing is the most common malignant salivary gland tumor occurring in the minor salivary glands. It is the most common which can occur intraosseously, that is in your mandible or occasionally in the maxilla as well, from the maxillary sinus. And it's also a tumor which can be seen in children. Otherwise, all the salivary gland tumors usually occur in elderly age group. This is one of the tumor which can occur in children. Okay, so these are some things which you need to remember about mucoepidermoid carcinoma. So again, depending upon the grade, the clinical presentation varies. In low grade, it may be fluctuant, slow growing. It may resemble a mucocele, whereas in a high grade, again, it may show rapid growth, ulceration, and invasion into the adjacent tissues. So intraosseous emesis, probably arising from the Staphne bone cavity. It's usually from the salivary glands which are present in the maxillary sinus. So usually presents as a ill-defined radiolucency in the posterior third of the mandible. Okay, so gross examination also varies depending upon whether it is low grade or high grade. So it is a predominantly cystic malignancy. So it's not like adenoid cystic carcinoma where there are pseudocysts. Here there are actual cysts which can be seen even in the gross. So you have a cyst here which is filled with mucoid material. So that can be seen on a gross examination. So it's a cystic malignancy. Whereas in high grade, it is predominantly solid. So you do not have any, it will be whitish, invading into the adjacent the normal salivary gland you can see here. And it here also you can see invasion into the adjacent tissues, and it is does not have any cystic spaces. The cellular components are important to in mucoepidermoid carcinoma. You have 3 cells, which we already mentioned. You have the mucus cells. So these are your mucus cells. They are large, they are round to ovoid with a peripherally displaced nucleus, and they have a basophilic cytoplasm. And then you have your epidermoid cells, which resemble your squamous cells. So they will be round to ovoid or polygonal. The cell boundaries may or may not be very prominent. There are some which are prominent, or sometimes you may have a syncytium-like arrangement, but there is abundant eosinophilic cytoplasm. And then you have the intermediate cells, which are considered to be intermediate between basal and epidermoid, and they will be usually flattened or spindle shaped. It's not very clear in this. This is another area. You can see this. These are your intermediate cells. So intermediate cells appear to be hyperchromatic. They can be flattened and they can be spindle shaped cells. So these are the 3 cells that you need to look for. Apart from that, you can get clear cells, you can have oncocytes, you can even have goblet cells and ciliated cells. So those are the additional components, but these 3 are something you need to look for. So this was the case of a extremely low grade mucoepidermoid carcinoma. It was infiltrative, but it was cystic. So you can see it is infiltrating into the adjacent muscles, but it is predominantly cystic. It was a single cystic cavity lined by flattened cuboidal, and then you have some amount of hyperplasia which was seen ahead. Again, you can see the infiltrative aspect of it, but it was predominantly cystic. So if you see the cyst, it was lined by all the 3 types of cells. We had mucus cells, we had your epidermoid cells, and also we had the intermediate cells. You could also see some mitosis there. So this was signed off as the low-grade mucoepidermoid carcinoma. So if you have an intermediate variant, usually you will have less cystic spaces. You will have more solid islands. So there are cystic spaces, but there will be more of solid islands. So if you see the previous one had, it was predominantly cystic. That was the extremely low-grade one. It would have been easily mistaken for a retention mucocele. This one is the intermediate one, which had a lot of cystic as well as solid mixed. Okay. So you had all your epidermoid cells. So you can see these pink cells with vesicular nuclei. These are all your epidermoid cells. You have a lot of clear cells, very less mucus cells. I think it is there in the subsequent area. You can see the papillary projections that the epithelium is projecting into. Predominantly, you have a lot of epidermoid cells here. Okay, so this is the hyperview. You have your epidermoid cells. Okay, you have your clear cells. Can you see some dark cells here? So these dark cells, which appear to be nondescript, very small, they are your intermediate cells. Okay, so these are your intermediate cells. So some areas you can see duct-like arrangement, and then there is some cells within the lumen which are appearing more pink. Could be an oncocytic change which has occurred in a mucoepidermoid carcinoma. You have to expect these changes. So the hyperview of that, these are all epidermoid cells. The darker ones are your intermediate cells, and then you have your oncocytic cells. You can see your epidermoid cells here showing prominent intercellular bridges, cystic areas filled with mucin. So you can see these are your epidermoid cells. These are again your intermediate cells. Some mucus cells here. Mucus cells are something that you need to look for either by doing a special stain for mucicamin to finally give a diagnosis of mucoepidermoid. So papillary projections, some dark intermediate cells are very clearly seen here. The darkly stained ones, rest all are your epidermoid cells. Some of the cells were showing eosinophilic granular cytoplasm. Probably this is an oncocytic change. It was seen in this papillary projection, presence of oncocytes, hyperview of the same. You find eosinophilic granular, slightly larger cells, they are your oncocytes. So focal areas of oncocytic change can be seen if it is very, throughout it is found, and in most areas, more than 70%, we call it as an oncocytic variant of mucoepidermoid carcinoma. So this was a high grade, that was intermediate grade. Then we go to the high grade variants. So high grade variants are predominantly solid. You do not get cystic areas there. So these are all solid islands which are proliferating into the underlying connective tissue. The islands are made up of pleomorphic cells. So you can see pleomorphism, you can see hyperchromatism, the epidermoid cells, because it behaves more like a squamous malignancy. So you have features which are similar to a squamous cell carcinoma, and often you may get confused with a squamous cell carcinoma when you're signing out a high grade MEC. You can see there is necrosis in most areas. Focal areas of keratin pearl formation can also be seen. Look at the pleomorphism. None of the other cases we saw, even if they were malignancy, they were not showing this sort of a cytology, but this is a high-grade MEC which is showing pleomorphism, brisk mitosis, almost 4. I think there are 5 to 6 per high power field here, and then you have your presence of some amount of keratin pearl. Yeah. So these are the areas. So to give a diagnosis of mucoepidermoid carcinoma, you may have to go in for immunohistochemistry in these type of cases, because it's very difficult to differentiate from squamous cell carcinoma. Do a special stain, mucicamin in focal area, find mucous cells, then you can have confidence that it is a mucoepidermoid carcinoma. Otherwise, it is very difficult to differentiate from squamous cell carcinoma. We'll be covering that part subsequently in the diagnostic pitfall, how to differentiate it. Okay, one more case of a clear cell mucoepidermoid carcinoma. This case presented with sheets of only clear cells. There was clear cells everywhere, lot of islands filled with clear cells. The clear cells had nice boundaries, well-defined boundaries, centrally placed nucleus. Few epidermoid cells were also seen at the periphery, but otherwise there was nothing. There were focal areas of duct-like areas and focal area pearl formation. It was invading into the bone. But then we did a mucicamin, and we could see that there were presence of mucous cells. So mucicamin is a very good stain, especially for identification of the mucous cells, and then to give a diagnosis of clear cell mucoepidermoid carcinoma. It was an extremely tricky case. It was not easy to diagnose, and this was the case. I just put it in because this was the case which we had sent it to Dr. Gary Ellis in AFIP for the diagnosis, and he concurred with our diagnosis. This was during my post-graduation. And this is another mucoepidermoid carcinoma, which is the intermediate grade, because there are some cystic spaces, lot of solid areas, hyperview showing the clear cells, the epidermoid cells, and then we had a lot of these cells distributed throughout. So you can see these cells. So these are your epidermoid cells, slightly lightly stained. But these are the cells that you need to focus on in multiple areas. Dark staining, eosinophilic, granular appearing with a centrally placed nuclei. Okay, hyperview of the same. You can see all of these granular, the centrally placed nuclei appearing slightly larger. How they are different from epidermoid cells, slightly light eosinophilic cytoplasm, whereas here the cytoplasm is granular. Multiple areas throughout the tumor. There were all of these cells which were present throughout the tumor. Again, here you can see this. I think this is a better picture where you can see some of them are separated, and you can see the granularity again here, the granular cells. So these are all oncocytes. So almost more than 70% of the tumor, apart from the mucous cells, epidermoid cells, you had these oncocytic cells. So we gave a diagnosis of an oncocytic mucoepidermoid carcinoma. So you can see this. So this is oncocytic mucoepidermoid carcinoma. Oncocytes in a mucoepidermoid are very often seen. So please look for it. I think the last carcinoma, last but one, is the actinic cell carcinoma. So actinic cell carcinomas resemble salivary acini. So you have to look for serous SNR differentiation, and serous SNI appear purple, which we covered already in the normal histology when we were covering. So what you need to look for when you see a serous SNI in the microscope is the basophilic hue, or the purple appearance of the slide. The entire slide appears purplish because of the SNR cells which are there. It also shows a lot of architectural diversity, and there are variants which are reported. So this is what I was talking about. It appears purple as compared to your blue and pink, which you see in most of the other tumors. Here it appears to be purple because of these acini or SNR cells which appear granular and take up a pink cytoplasm because of the purple cytoplasm, because of the zymogen granules and abundant amount of mitochondria. So you have different types of cells. These are your SNR-like cells which are most prominent, and that's what you need to look for to give a diagnosis of actinic cell carcinoma. And then you have intercalated ducts, which appear to be more cuboidal. I think they are in the next picture. Okay. So if they are appearing more cuboidal, round to ovoid, we call them as intercalated cells. Then you have vacuolated cells, which is very specific for ethnic cell carcinoma. So you have clear cells, but they will be in the form of multiple vacuoles. Okay. So they will, this is a clear cell, which is clear in the sense they will not have any vacuoles, but you can have, I think there is another one. Yeah. These are the multiple vacuoles that you can see. So these are your vacuolated cells. These are your SNR cells. The cuboidal ones are your intercalated cells. The non-specific glandular cells are difficult to define. Any other cell other than what you don't want to define, these will be called as non-specific glandular cells. So they have different types of cells. What you need to look for is the SNR cells, which usually are pass positive and diastase resistant. The arrangement also varies. It can be solid in the form of sheets of cells, or it can be microcystic, where you can have some small cystic areas, and then it can be papillary cystic. Then you may have to differentiate it from a papillary cyst adenocarcinoma, or it could be follicular, where you have these typical thyroid looking globules which can be seen. You have to do a thyroglobulin to rule out that it is not thyroid tissue. Okay, so this is the follicular variant of ethnic cell carcinoma, though it is being considered as one of the common tumors, not very commonly encountered. And then you have polymorphous low-grade adenocarcinoma. So they are, as the name suggests, it is polymorphous. The cells are isomorphic, monotonous, same type of cells, lot of morphology. So one benign tumor which had a lot of polymorphous, and it was called as pleomorphic adenoma. Mixed tumor is your pleomorphic adenoma, and often because of this architectural polymorphism, which is a hallmark of PLGA, PLGAs are often misdiagnosed as pleomorphic adenoma. But definitely the presence of the chondroid matrix, presence of plasmacytoid cells should highlight it to be a pleomorphic adenoma. But the architectural diversity that is seen in pleomorphic adenoma is to a certain extent reflected in polymorphous low-grade adenocarcinoma. But the cells, small, bland, very glassy looking, and very typical. If you see the cells, it's very easy to identify. They have a specific propensity for perineural invasion, and they have a specific type of neural invasion, which is referred to as targetoid. So this was the case which occurred in the palate. Again, you can see extending into the maxillary sinus and the nasal cavity. It's considered a low-grade malignancy, but definitely it is a malignancy, so it is infiltrative and invasive. And this was the gross picture, a lot of areas of hemorrhage, and you could see this was the tumor mass. So histologically, you had polymorphous appearance. So the cells were arranged in the form of sheets, they were arranged in the form of ducts, and they were also arranged in the form of islands. So polymorphous low-grade adenocarcinoma has a polymorphic morphology, in the sense it is arranged in multiple ways. So here you have sheets of cells, you have also islands and tubules, areas of cystic degeneration, areas of hyalinization are also seen here. This is the hyper view of the islands. They are also arranged in the form of tubules. You could also see ducts, some of them arranged in the form of interconnecting cords. Again, you have sheets of cells here. So again, the ducts and cords which are seen in high power, along with the areas of hemorrhage. Cystic papillary pattern is also something that you can see. So this is the cystic papillary pattern. Observe the cells. We will go to high power subsequently, but observe the cells. So then you have the myxoid areas and hyalinized areas. So because of the variation in the morphology, and because palate is the common site, many times we may confuse it for a pleomorphic adenoma, but you have to look for infiltration, invasion, areas of necrosis, not very common, but you may find presence of that, which will help. But the most important point is the cells. The cells appear almost ghost-like or glassy. They are round to ovoid with minimal cytoplasm, and the nuclei appears almost empty. Okay, so the empty looking nuclei is something that you need to look for when you're giving a diagnosis of a polymorphous low-grade adenocarcinoma. The chromatin is extremely dispersed and they appear empty looking. Focal areas may show cribriform patterns, so ACC might come in as a differential, but you have a lot of other patterns which are not seen in ACC. You can have the single file pattern, also referred to as the Indian file pattern, which you need to look for, may not be present in all, but that is one of the characteristic feature in PHGA. So again, look for the cells, empty looking nuclei. Okay, so this is very characteristically different from that of adenoid cystic carcinoma, where you had hyperchromatic angulated nuclei. Okay, you have targetoid PNI in the sense that the cells which are invading are arranged in the form of a concentric circle around the nerve tissue. Okay, so that's polymorphous low-grade adenocarcinoma, and then you have salivary duct carcinomas. So the name salivary duct carcinoma was given because it looks like breast carcinoma cancer, that is ductal carcinoma of the breast. So it looks like breast cancer, it behaves like a beast. It's considered to be one of the highest grade tumor, and it has a very high rate of recurrence, very poor prognosis. The survival rate is very low, and most of the patients who present with salivary duct carcinoma already have developed metastasis. So the key features, it is a high grade adenocarcinoma, aggressive clinical behavior. They will be early nodal and distant metastasis. You have ductal differentiation. The cells appear like they are large ducts which are undergoing necrosis. So they are lined by large polygonal cells with abundant eosinophilic cytoplasm. So there are various patterns that you can see. You can see solid, cribriform, and papillary. So all our architectural bucket has come here. So it could come in the differential diagnosis of any, but clinically it will be a very high grade tumor. So this is your salivary duct carcinoma. It's a solid variant. You can see it is invading into the adjacent tissue. The characteristic finding is presence of these large sheets of cells which have central areas of comedonecrosis. Okay, you can see these areas of comedonecrosis, which is very characteristic, and see the cells. The cells are usually large, polygonal, often granular, with a centrally placed nucleus, which may show pleomorphism. Okay, so it can show pleomorphism and variation in size and shape, brisk mitosis. Okay, and you can have a low-grade variant, in the sense, little low-grade, an intraductal variant of salivary duct carcinoma, where you have these large duct-like spaces and with the nuclei, with the cells arranged in the form of a Roman bridge pattern. So this is the Roman bridge pattern that is commonly seen. So these are intraductal salivary gland carcinomas, duct carcinomas, which are located within the duct. They have not yet come out into the adjacent tissue. Very rare to see this. This is the intraductal salivary duct carcinoma, whereas the previous one was the invasive one. And then we have the clear cell carcinomas of salivary glands. So clear cells, they are made up of predominantly clear cells. Okay, so there are two main, that is hyalinizing clear cell carcinoma and myoepithelial carcinoma. And if they do not fit into either of the two, you can call that as a clear cell carcinoma, not otherwise specified. Epithelial myoepithelial carcinoma is predominantly seen in the parotid. It is a biphasic tumor. Very characteristic feature, you have the central lumen filled with eosinophilic material. You have your intercalated duct cells. Peripherally, you have your myoepithelial cells, and surrounding that, you have your basement membrane-like material. Okay, so the central area, they say it may be Alcian blue positive. The peripheral area is Pars positive. It's very diagnostic. Presence of these areas in multiple areas, you can find these typical appearance, and that will give you a clue to the diagnosis. And then you have the hyalinizing clear cell carcinomas. These are more common in the minor salivary glands, palate, 80% of cases. And you can see this is predominantly made up of clear cells. They are neither Pars positive nor mucicarmin positive. Helps you to differentiate from a clear cell mucoepidermoid carcinoma. You have to differentiate it from a metastatic renal cell carcinoma, which are both glycogen positive, and then you have to go for immunohistochemistry in case you need to rule out metastatic renal carcinoma. Apart from that, you have a lot of vascularity which you see in metastatic renal cell carcinoma, which may not be seen in a hyalinizing clear cell carcinoma. So that covers most of it, most of the tumors. We'll just take another 10 minutes to cover the common diagnostic pitfalls. The common diagnostic pitfalls in why malignant salivary gland tumors mislead and confuse is because of their bland cytology. And bland does not mean benign, and ugly does not mean aggressive. So it's literally challenging whatever we have learned in oral pathology. So adenoid cystic carcinoma is bland, but it's definitely not benign. It's a highly aggressive tumor. Basal cell adenocarcinoma appears basaloid, but it's not as aggressive as your, it appears more cellular. It appears more sinister than your adenoid cystic carcinoma, but it's considered to be a low-grade malignancy. So you need to be very particular about which pattern you want to put it, and then again within the pattern you have to have an idea about which are considered as low grade, which are intermediate, which are high grade. So AFIP classification comes into play here, and you have to know which of them should be categorized as low risk, intermediate risk, because the therapy usually varies based upon the type of classification or diagnosis that you give. So most commonly, as I told, basal cell adenoma versus basal cell adenocarcinoma, I already mentioned about it. There will be a well-defined capsule in basal cell adenomas, whereas they are infiltrative in adenocarcinomas. A low-grade mucoepidermoid carcinoma versus a mucus retention cyst. So if it occurs in the upper lip or it is in the palate, just as a fluctuant single cyst with mucin filled within it, it may be very easily confused with a mucus retention cyst. But you have to look for the lining. So the lining is vastly different. It will have all of these three components, that is presence of mucus cells, epidermoid cells, and intermediate cells, whereas a retention cyst will have a lining of a ductal epithelial lining. So the identification of these cells will help you to not commit a mistake of underdiagnosing a low-grade mucoepidermoid carcinoma. And then you have adenoid cystic carcinoma versus polymorphous low-grade adenocarcinoma. If there are cribriform areas present, because here also you have dark cells, here also you have dark cells, but here you have angulated nuclei, here you have glassy nuclei, and PLGAs usually will be MYB negative. So this is an important marker that you can use to differentiate adenoid cystic carcinoma from PLGAs. So this is MYB positive, this is negative. PLGA are low grade carcinomas as compared to ACC. So the Ki67 levels will be up to 25% in ACC, whereas in PLGA up to 10%. And there is a characteristic fusion which is seen in ACC, that is the MYB and FIB fusion, which is positive in ACC, whereas negative in PLGA. And this is an important distinction which you need to do, because PLGA are extremely low grade malignancy, your adenoid cystic carcinomas. And then you have your solid adenoid cystic carcinoma versus a solid basal cell adenocarcinoma. Both have dark cells, okay. And but what you find in solid ACC is presence of not much of polymorphism, in the sense the presentation of the patterns are not very evident, whereas here you can have some basement membrane like material, you can have but if it is an extremely solid variant, it may resemble adenoid cystic carcinoma. So the points that you need to take care is, it is perineural invasion, more common in adenoid cystic carcinoma, not very common in basal cell adenocarcinoma. Presence of lumina absent in both. Necrosis is common in a solid adenoid cystic carcinoma, whereas rare in case of basal cell adenocarcinoma. As I told you, they are hyperchromatic and angular, whereas here you have uniform round to void cells. Mitotic rate high in ACC, and necrosis also is very common in ACC as compared to a basal cell adenocarcinoma. And the Ki67 levels, of course, are higher in ACC as compared to basal cell adenocarcinoma. So this will help you to differentiate between the two. So role of IHC in malignant tumors, it is needed only when you want to see the tumor is poorly differentiated, as was the case in the previous one. And you have both of them being basaloid or cribriform or high grade, and you don't know where exactly which category it is going to fall into. And you have multiple malignant differentials. For example, a mucoepidermoid carcinoma with a lot of lymphocytes may be confused with a lymphoma. So if you have those sort of a differentials, definitely go in for IHC. And if the treatment decision depends on the subtype, go for IHC. So some common IHC markers which will help you to come for diagnosis. You have a cribriform or a basaloid tumor, especially in the previous case where you had in a ACC and a basaloid adenocarcinoma. Go for CD117. It is positive in ACC, so that gives the diagnosis. And if it is a bland and infiltrative tumor, you can do SOC stain, which shows it's a salivary lineage. If it is a squamoid high-grade tumor like a high-grade mucoepidermoid carcinoma, and you cannot differentiate it from squamous cell carcinoma, do a P63 or a P40. So P63, P40 more seen in only the basal layer in case of mucoepidermoid carcinoma, whereas you have diffuse positivity in squamous cell carcinoma. If you have breast like morphology or ductal carcinomas, you have to go for androgen receptor or HER2, which is positive, which is not so in other tumors. Clear cell tumors, do a SMA or calponin. The most common clear cell tumor is your epithelial myoepithelial carcinoma and a hyalinizing clear cell carcinoma. Hyalinizing clear cell carcinoma do not have myoepithelial cells, so they will be negative. So if it is positive, it is epimyoepithelial carcinoma. If there are cystic spaces, mucous cells, you have to do mucin markers, which confers mucoepidermoid carcinoma, and Ki67 will help you to grade it either into a low or high grade, because grading is very important for the prognosis as well as the treatment. Now, what is the role of molecular testing in malignant tumors? When the morphology and IHC are confusing. So you have the morphology, you have done the IHC, but still it is confusing. I'll show a case in point subsequently. Then you go for molecular testing. If the tumor has a lot of overlapping patterns and you're not sure you want to categorize it into which particular entity, a signature fusion is suspected. Why the fusion is important to know? Because there are a lot of targeted therapy which is now available. Based on the fusion, they usually give the targeted therapy. The subtyping of the tumor, which will help in changing the management, or patient is in advanced or metastatic stage. You don't want to do a biopsy, you directly want to do a, you want to do a treatment, then go for a molecular testing and then confirm your diagnosis. So that could be one of the reasons why you should use a molecular test. For ACC, you have a typical MYB-L1 NFIB fusion. For polymorphous low-grade adenocarcinoma, you have the PRKD1 mutation. So if you are in doubt, you can do either of these to confirm. For mucoepidermoid carcinoma, you have the MA-ML2 fusion. For targeted therapy, especially for salivary duct carcinoma, you have to look for HER2 amplification. And the newer entities are molecularly defined. So if it is a secretory carcinoma, usually it will be ETV6, MTRK3 positive. So these are few molecular tests that you need to keep in mind. Let's see a case in point when you may use molecular testing. A 55-year-old male came to our department with a slowly enlarging painful swelling, which was in the base of the tongue and extended onto the lateral border. So this is what was seen, but the CT scan did show that it was extending further into the pharyngeal areas. So it was in the base of the tongue. So what we saw was an infiltrative tumor with irregular borders, which was well separated from the overlying epithelium. Overlying epithelium was well separated, so we didn't think it to be arising from overlying epithelium. It was something coming from down. The overlying epithelium was atrophic, no evidence of dysplasia. You had a lot of these islands and sheets of epidermoid appearing like cells or squamoid cells intermixed with central areas having clear cells. A lot of this secretion which was seen, which was giving a feel of a salivary gland tumor. Areas of perineural and lymphovascular invasion, PAS positive, musicamen negative. Okay, so which as per the diagnostic framework, which primary architectural bucket will I be putting it into? It's definitely not cribriform, not cystic, it is solid. So then I go for evaluation of the cells. I have seen epidermoid cells. I saw clear cells. They were arranged in islands and sheets. There was some eosinophilic material being secreted. There were no obvious duct-like structures, but the overlying epithelium was normal. So it was definitely an epithelial malignancy. So we were thinking more in terms of a salivary gland tumor. So the most likely diagnosis could be either a squamous cell carcinoma, a clear cell squamous cell carcinoma, or it could be a mucoepidermoid carcinoma, considering there were so many epidermoid cells, or if you cannot classify into any, we usually call it as adenocarcinoma, not otherwise specified. Now, the morphology is equivocal here. It is very confusing. It's not actually giving me a clear-cut diagnosis, so not sure. So we went in for immunohistochemistry. It was P63 diffusely positive, P40 diffusely positive, CK7 positive, S100 negative, P16 negative. We got it done at AIMS, so this particular immunohistochemical panel. So the CK7 positivity suggests that it is salivary gland epithelial origin, or rather ductal origin. And P40 and P63 is more for squamoid marker. So usually in SCC, you will have diffuse strong positivity. In a MEC, you can have positivity, but only in the epidermoid cells. In adenocarcinomas, not otherwise specified, they will be negative. S100 myoepithelial cells. In MEC, usually negative. In SCC, negative, but in adenocarcinomas, usually positive. P16 was done because it was predominantly a non-keratinizing, malignancy with no evidence of any keratin anywhere. And HPV-associated tumors are usually non-keratinized. So P16 was negative for us. So here we were just thinking of HPV-related SCC. So our tumor was CK7 positive, P63, P40 diffuse, S100 negative, P16 negative. So if you see the panel for mucoepidermoid carcinoma, it should have been only in the basal, S100 negative, P16, CK7 positive. But more towards squamous cell carcinoma, here you see P63, P40, S100 negative. But again, it should have been CK7 negative, but it was CK7 positive. We ruled out adenocarcinoma because it was P63 and P40. Still, the confusion remained with mucoepidermoid carcinoma and squamous cell carcinoma is because of this CK7 positivity. So we ordered for a molecular test, that is MAML2 by FISH, and it came as negative. So MAML2 break apart probe showed an intact signal with no break apart pattern identified. So rules out MBC, and the final diagnosis was given as non-HPV associated SCC. So in conditions where you cannot actually categorize it into a particular tumor, you may go in for IHC and molecular testing. If the morphology is very clear, then you need not go for it. Okay. So the take-home message for the last malignant salivary gland tumors: patterns still matter as it mattered for benign tumors. Malignant tumors invade, they do not expand. Bland cells can still kill. Architecture is the one that you need to look for. Perineural invasion, if you find, never innocent. And grade changes the management, so grading is something you need to do. So malignant tumors may look bland and familiar, but they are always break the rules. So the conclusion for the entire webinar is, when in doubt, always zoom out. Low power observation is your diagnostic superpower. Okay, so you see for low power, look for the changes that you need to look for in a, and of course you need to have a large biopsy. Small biopsies, it may not be possible, but you need to correlate it with clinically. Salivary gland tumors are not typically malignant as your squamous cell carcinoma, so correlate it with clinical correlation. See if it is infiltrative, invasive, and look at low power for all the changes that you have. Patterns save you. You should know your morphology. You don't need more stains. You don't need IHCs. You don't need more genes. What you need is diagnostic reasoning. So architecture and then cytology. These are my references. I would like to thank my alma mater, SDM College of Dental Sciences, for giving me the foundation of oral pathology person. I'm extremely thankful for the range of cases that I could see during my post-graduation and subsequently when I worked there. And of course, I'm thankful to KLEVK, Institute of Dental Sciences, for nurturing this further. I thank my mentor and guide, Dr. Rekha K, for instilling the passion of oral pathology in me, and especially salivary gland tumors was something that both of us always used to discuss on. All the faculty, postgraduates, and my consultant, Dr. Ria, Dr. Jayanta, and Dr. Subbalakshmi from Kusum Devi College, and all the participants who were present through this entire series, for joining us to decode salivary gland tumors. I'm sure at the start of the session, you must all have felt that it is a topic which is very difficult, and how do we remember all the tumors. I hope you, at the end of this series, you have learned something useful. It may not be answers to all your questions, but I've tried to put forth a way to think and a way to decode these complex tumors, because in real practice or in exams, if you have a structure, if you know the patterns, I think you may not be lost.
Thank you, ma'am. Wow, that was truly a power-packed presentation and extremely intense, yet so lucid at the same time. And you've simplified these complex entities so beautifully to us. Thank you very much.
I'll just stop. Okay. Yes.
Yes, ma'am. So now we'll start taking the questions.
Yes.
And the first question is, what is the use of PAS stain in differentiating basal lamina, duplication, and mucin, and its diagnostic significance?
Okay, so PAS will take positivity for even for mucin as well as for basement membrane, but you have to assess along with it. or you can go for Alcian blue or mucicarmine, which is a general purpose stain. So that will differentiate between mucin and basement membrane. Do you want to know where you have to use it? Is that the question? Yes. Okay, so the question is where you need to use PAS. Most of the salivary gland tumors, wherever there is eosinophilic material, will be PAS positive. Mucicarmine will play a very important, especially in diagnosis of mucoepidermoid carcinomas, especially high-grade tumors where you have epidermoid and intermediate cells. You need to look for mucus cells, and mucus cells usually come positive with mucicarmine. And if you have a mucicarmine positivity, then you can give a diagnosis of mucoepidermoid carcinoma. Even for clear cell mucoepidermoid carcinomas or clear cell tumors, you need to have a list of special stains that you need to do. Mucicarmine will point towards mucoepidermoid carcinoma. PAS points towards glycogen positivity, but glycogen positivity can also be seen in a clear cell epimyoepithelial carcinoma, as well as in I think in clear cell odontogenic carcinomas, for that matter, if it occurs in the maxilla. So at that point of time, PAS may not play a very important role. Then you have lipid stains which are being used for sebaceous carcinomas. So you need to have a panel, a PT8 stain for a clear cell oncocytoma. So you do the special stains, rule out one by one, and then come to the final diagnosis.
A question on jigsaw puzzle pattern.
Yes, that is very commonly seen in the membranous variant of basal cell adenoma, as well as in basal cell adenocarcinoma. That is because of the basement membrane material which is present in between. But usually it is associated with some syndrome. So you have other features which can also be present. But otherwise, also in a basal cell adenocarcinoma, you can have lot of basement membrane like material.
Next question is cribriform variant of polymorphous adenocarcinoma and mammary secretory analog carcinoma.
Yes, you do get it. I didn't add that. Thanks for pointing out.
There is a suggestion that we could have a session on cytology in salivary gland neoplasm diagnosis. Thank you so much for the suggestion. We'll definitely think this through and probably take it forward.
Expert in cytology of salivary gland tumors. We do not actually use cytology to that extent. I think Dr. Asitva Mondal is expert in that, because FNAC has to be used along with cell block and molecular biology. FNAC alone is not going to help us in diagnosis of salivary gland tumors. I think yes?
Yes, ma'am. There's another question. Madhura ma'am has asked that please explain your experience with cribriform adenocarcinoma of minor salivary glands and PLGA.
So I have not seen any case of a cribriform adenocarcinoma of the minor salivary gland. Definitely, I have seen polymorphous low-grade adenocarcinomas, but cribriform adenocarcinoma of the minor salivary glands more common in the tongue. PLGAs are more common in the palate. So we have seen a lot of cases of polymorphous low-grade adenocarcinoma, and I think that's some of the cases which I already presented. Any particular thing you wanted to know?
Any questions, any further questions? We will take them in the next few minutes.
Is asking about the biological behavior. The biological behavior, they are more aggressive as compared to PLGA. PLGA are considered to be extremely low grade as compared to that.
But that is quite a dichotomy, because they show perineural invasion, and despite that, and they have, they're not well encapsulated and things, but it's very strange why the biological behavior is not very aggressive. Yes. And anybody else? Any further questions?
So salivary gland tumors are a mystery, and you have to keep on, seeing multiple cases, and then only you can actually see how exactly each one of them behavior. What is your opinion about metastasizing pleomorphic adenomas? So metastasizing pleomorphic adenoma, I have not seen a case, but metastasizing pleomorphic adenomas are benign pleomorphic adenoma which present with metastasis. This usually happens in case of recurrent pleomorphic adenomas or recurrent surgeries which have been done, which causes some sort of a mutation, and that causes metastasis of the tumor. So the metastasis exactly resembles a benign pleomorphic adenoma.
Okay, and how much of the diagnosis depends on special stains and IHC?
Special stains, definitely. IHC, especially in malignant salivary gland tumors for grading, yes, you can use it. And also in equivocal tumors, where tumors appear similar, like in where I gave you multiple examples, in those cases, definitely IHC plays a role.
And I think, yes, ma'am, there's another question. How to differentiate a cribriform adenocarcinoma from, I think, other cribriform variants of other carcinomas?
Cribriform adenocarcinoma not otherwise specified, yes, you need to cribriform adenocarcinoma per se will not be typical cribriform. Are you talking about which adenocarcinoma are you talking about here? The mucinous cribriform adenocarcinoma, not very common actually. Adenoid cystic carcinomas are relatively more common. So it's always better to have the incidence in mind. So the commonest tumors take first into the diagnosis. The uncommon ones will come subsequently. And also,
Are there any more? Sorry, ma'am, please.
Oh, sorry. Site specificity is also very important. You have to take into consideration certain tumors which are more common in certain sites. So clinical pathologic correlation also plays a very important role.
Any further questions?
Any questions, they can always mail also. I try to answer as much as I could, but definitely I would like to learn more and know more, and I would like to answer all the questions that you have.
Thank you very much. Thank you so much, ma'am. And I'd like to request Dr. Joyita Chattopadhyay, sir, Principal and Head of Department of Oral Pathology of Kusumdevi Sundarlal Dugar Jain Dental College and Hospital, to please say a few words.
Thank you, Shiva. Am I audible?
Yes.
Good morning, Punya.
Morning.
Good afternoon, Punya and Dr. Shiva. It was indeed an enriching session, clearing our day-to-day doubts with a very relevant topic. I've been following these sessions over the last 3 weeks. Personally, it cleared a lot of my doubts. On a broader note, our subject is so vast and evolving so fast, it is not possible to master the whole of it during our days of PG training. So we need to keep on upgrading our knowledge over the period of time. But during our working life, it becomes very difficult to accommodate the time, the money for traveling, accommodation. So we have decided to use technology for the spread of knowledge and concepts. My sincere thanks to Dr. Punya Angadi Rao for taking all the trouble to present such a complicated topic in a lucid way. My heartfelt thanks to Dr. Sen for choosing such a relevant topic and working tirelessly to make the idea a success. My thanks to a whopping 680 people who have registered for this webinar, as I came to know. Now, we as an institute promise to come back with many more of such webinars pertaining to important topic and continue our effort to have a humble contribution for the enrichment and the spread of the subject of oral pathology. Before I take your leave, I would like to mention this 27th of February 2026, we are having the IMP National CDE in Kolkata at our institute. Dr. K. Ranganathan sir, Dr. Gururaj Rao, our respected secretary, and Dr. Lavanya from Ragas Dental College, Chennai, will be present as the resource person. Our president, Dr. Nadim Jedli, have kindly consented to be the guest of honor. We shall keep informing you about the various aspects of the program in due course. Kindly make it convenient to attend the meeting on 27th of February at KSD Jain Dental College, Kolkata. Thank you, everybody. Thanks once again, Punya. Give my regards to ma'am.
Sure, I'll tell her, sir. Thank you so much.
And thank you, everybody. I hope all of you had an enriching session. Thank you.
Thank you.
Thank you, sir. And as a token of appreciation, we would like to present a certificate to ma'am on behalf of the Department of Oral Pathology. And I request the certificate to be please displayed on the screen.
Thank you. Thank
So
you
we
for
present this certificate to ma'am. And thank you so much for the absolute tireless effort that you've put in to bring this whole thing together and making this complicated topic so easy for not just faculty, but also for the students, both at the PG and undergraduate level. And we're really, really thankful to you, ma'am, to have you on board with us. And a very special thank you to all our participants. And this is for your information that your participation certificates shall be mailed to you in the next 1 or 2 days, along with a feedback form. We'd be extremely appreciative if you do respond to that feedback form so that we can improve and conduct better webinars in the future. And for all the suggestions that you've put forth, we will surely try to work and get more sessions in place. Thank you so much, all of you. Have a wonderful day.
Thank you.